Hi guys, this is Renee. I'm going to be your instructor for this content. I've decided to split the sexuality voiceovers into two parts. The first part's going to focus on wellness topics. This includes the menstrual cycle, menopause, health promotion, sexuality across the lifespan, sexual history, and other similar topics that will all incorporate into maintaining wellness. You guys are going to notice this lecture does not follow along in order with the book. And that's because many of the topics that are in this lecture are going to be covered in different textbook readings. The next voiceover will focus on common sexual disorders, and we're going to pay particular attention to sexually transmitted infections. So this is just a list of the topics that we're going to cover in the voiceover. We're going to talk about what sexuality is, some key terms, sexuality across the lifespan, the menstrual cycle, menopause, routine screenings that are very important. We'll discuss factors that affect sexuality, how to obtain a sexual history, the Plicit model, and sexual health education topics. So what do you think of when you see the term sexuality? This term conjures all sorts of images, and guaranteed each of you listening to this probably envisions something different. The World Health Organization states that sexuality is experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, behaviors, practices, roles, and relationships. Sexuality is a central aspect of being human throughout life and encompasses sex, gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. Many people think that sexuality is synonymous with sex, which is actually incorrect. Sex has multiple meanings, one definition being whether an individual is male or female. Okay, so some key terms and concepts related to sexuality. Gender refers to an individual's biological sex status, XX or XY, which is determined at the moment of conception. This should not be confused with gender identity. Gender roles refer to societal normal regarding gender-appropriate behavior. These gender roles evolve over time and can greatly differ between different cultures. For example, there were times where women were expected to either be housewives, or if they did work, they were expected to only have female jobs, such as like a secretary, a nurse, or a teacher. Gender identity is one component of sexual identity, and it involves the internal experience of how a person feels inside. This differs from gender in that a person may be born biologically female, but they may identify themselves or feel like a male inside. When this occurs, the individual is considered to be transgender or differently gendered. Transsexuals are people who identify with the opposite gender than their biology. Generally, these individuals will express frustration with their gender at an early age. So intersex people were previously referred to as hermaphrodites. These are people who are born with ambiguous sexual organs. In these cases, parents can decide which gender they want to raise their child as until they reach an age where they're able to choose on their own. A transvestite or cross-dresser is an individual who occasionally or frequently wears the clothes characteristic of the opposite sex as a form of sexual expression. Alright, so sexual orientation, on the other hand, will refer to a person's tendency to feel sexually attracted to people of a certain gender. Heterosexuals are sexually and emotionally attracted to members of the opposite sex. They are commonly referred to as being straight. Homosexuals, also referred to as being lesbian women or gay men, are attracted to members of the same sex. Bisexuals are attracted to both males and females. Now we're going to talk about sexuality across the lifespan. Birth through preschool, this is basically a time period when parental preconceived notions and thoughts of a specific gender role are instilled. Infants are going to develop their first attachment experience through bonding with their parent or caregiver. If any of you are parents, you probably have noticed that when children are this age, they enjoy being nude, they explore their bodies, and this is a normal part of child development. So school age through puberty, typically by this time, they are school-aged. Children identify with the same-sex parent and have mostly same-sex friends. Children are becoming more aware of gender roles and their own gender identity. As they enter puberty, secondary sex characteristics start to become more apparent. Masturbation may occur more frequently, and this is the time when children should be taught about body changes, menstruation, sex, and reproduction. Adolescence, this is a time of heightened sexual interest and activity due to hormonal changes that are brought on by puberty and culture's emphasis on sex. Masturbation is increasingly common, as is sexual exploration. This usually starts with kissing but can progress to genital contact. Unfortunately, given their developmental stage, most adolescents assume incorrectly that sexual activity comes without a health risk. They want to be treated like adults and make informed decisions, but it is vital that they have a proper understanding about the risks associated with sexual contact, such as unplanned pregnancy and STDs. Young adults. In early adulthood, people define their sexual identity and resolve any issues that they may still have with sexual orientation and self-concept. During this time of sexual maturation, many people find a life partner. They may make long-term plans, which may or may not include becoming a parent. Young adults may question whether their sexual behaviors and responses are normal. They also may still need information on contraceptive methods, STI prevention, and relationship or communication issues. Middle adult, life changes during middle adulthood. It may enhance or lessen physical and emotional intimacy. Typically, this is the time when their children have grown and moved out, and they may have more privacy and time to spend together. This can also be a time period when physical changes and chronic diseases emerge that could affect sexual health. This is the time period when menopause occurs and all the associated changes as previously described. Men experience a decrease in testosterone and can experience issues with sexual desire and the ability to achieve and maintain an erection. In the aging adult or the elderly, most older adults remain sexually active and regard sexuality as an important part of their life. It is important to recognize that older adults have sexual needs. However, sexual problems are more prevalent, but typically are due to failing physical health and medication side effects rather than just from age alone. Postmenopausal women may complain of vaginal dryness and experience pain with intercourse. Erectile dysfunction may be an issue for older men, and they should be encouraged to discuss this with their healthcare provider. If you look at the box 33-1 in Wilkinson, it reviews the normal physiological changes and sexual response that occur with aging. Just remember that sexual feelings do not necessarily disappear with age. So now we're going to talk about reproductive changes across the lifespan. I know some of these topics may have been discussed in other lectures, but I just want to touch on them because they're obviously associated with sexuality. First off, puberty. This occurs during adolescence and is the time of sexual maturation and starts the ability for reproduction. Multiple hormones trigger this development. It is the time period where secondary sex characteristics start to develop, including the growth of breast tissue and body hair. In order to determine where an individual is in puberty, the Tanner stage is used. Menopause is a stage of life that marks the permanent cessation of menstrual activity. There are 3 stages to menopause. Perimenopause is the first stage. It generally starts when a woman is in her 40s, and it is the time when a woman starts to experience menopausal signs and symptoms. It can last 4 to 8 years. Despite having irregular menstrual cycles during this time, a woman can still get pregnant. The second stage is menopause. This occurs after 12 months of amenorrhea, which is an absence of menstrual bleeding. The average age in the U.S. is 51 years old. And postmenopause is the third stage. This refers to the time after menopause. There are some common symptoms of menopause. Irregular periods, vasomotor symptoms, including hot flashes, night sweats, sleep disturbances, mood swings, and irritability. Loss, osteoporosis, increased fracture risk, central weight gain leading to cardiovascular disease, dyslipidemia, and type 2 diabetes. Osteoporosis is the loss of bone mass occurring when more bone mass is absorbed than the body creates. Some signs of osteoporosis include back pain, loss of height, stooped posture, bone fractures. Some risk factors for osteoporosis is thin, small-boned women, family history of hip fractures, smokers, sedentary lifestyle, calcium and vitamin D deficiencies, excess alcohol consumption, a BMI of more than 20, a history of eating disorders, a history of weight loss surgery, and certain medications. So this is just a review of the menstrual cycle. For women, menstruation begins in puberty, the first episode of menstrual bleeding being menarche, and involves hormonal changes that help prepare the body for pregnancy. The menstrual cycle is a monthly process mediated by hormonal activity of the hypothalamus, pituitary gland, and ovaries. Typically, menstruation occurs monthly when the ovum is not fertilized. On average, menarche is achieved by age 12 to 13, but sometimes it can happen earlier than that or later. The menstrual cycle begins on the first day of menstruation. This day is charted as the LMP, which is the last menstrual period. Menstrual bleeding usually lasts about 4 to 6 days, but it really varies significantly by individual. Okay, so routine screenings. Breast cancer screening, which is done through mammography. This is very important. The American Cancer Society recommends screening every year for women 45 to 54, and then every 2 years for women 55 and older. Cervical cancer screening, which is the Pap test, usually starts around 21, regardless of sexual activity. Women that are in their 20s will get this done every 3 years unless they have an abnormal Pap test. Women 30 to 65 years old can have one done every 5 years, but they will actually have a Pap with HPV testing. And we'll talk about HPV testing in the next voiceover when we talk about sexually transmitted diseases. Women older than 65 will also be able to stop having cervical cancer screening unless they've had a recent abnormal test. The DEXA scan, this is frequently based on health history and risk for osteoporosis, and it typically doesn't start until after the person is 50. Sexually transmitted infection testing, again, we're going to talk more about this in the next voiceover, but the frequency of this is just based on the risk and based on age. So there are several factors that affect sexual attitudes and behaviors. One of them is culture. Culture influences our ideas on gender roles, gender identity, marriage, sexual expression, and social responsibility. It can determine what is acceptable and what is not. For example, polygamy may be acceptable in one culture, but may not be in another. Religion is another powerful influence on sexuality. Many religions believe in restricting premarital sex, birth control, homosexuality, abortion, extramarital relationships, and masturbation. Some religions may even have rules regarding body coverings and modesty. Lifestyles can also influence sexual attitudes and behaviors. For example, family, socio-economic status, employment, and interpersonal relationships can shape our lifestyle, but they don't fully determine it. Day-to-day experiences create powerful impressions on the way we view the world and can even modify cultural and religious influences. Knowledge and education. Sex education varies between schools, and it is important not to assume that young adults have adequate sexual knowledge. Even if a state mandates sex education, individual schools may limit discussion on particular topics, such as birth control, STIs, intimacy. They may believe these topics should be addressed by the family or the church. Also, schools allow an opt-out option for children in regards to sex education. Some schools also require parents to give permission for children to attend sex education classes. So as sexuality involves the body, mind, and spirit, it should not be surprising that health status can greatly influence sexuality. For physical illness, disease, injury, and medical treatment can greatly influence sexual functioning. Most notably, heart or respiratory disease can cause excess fatigue and dyspnea on exertion. Diabetes can lead to neurological changes and therefore causing erectile dysfunction or loss of orgasmic ability. Cancer can not only cause body image changes, but the treatments can also cause nausea and fear of death. Some spinal cord injuries can make intercourse physically impossible, which will really depend on the level of the spinal cord injury. Surgeries can alter a person's body image, or at the very least leave a physical scar. When surgery involves body parts important to sexual functioning, negative effects can be even greater. Surgeries that can be at high risk for sexual health include hysterectomy, which is removal of the uterus, a mastectomy, which is removal of the breast, a prostatectomy, which is the removal of a prostate gland, an oophorectomy, which is the removal of an ovary, which can also alter hormone levels, and a colostomy. Mental health issues and psychiatric disorders can lead to interpersonal disruptions and difficulty with sexual expression. This can lead to either decreased sexual drive or the potential for promiscuity, dependent on the illness. Finally, there are medications used to treat various health problems that can have undesirable sexual side effects. If you look at page 858 in your book, table 33-1, there's a list of common effects that drugs can have on sexual function. In addition to general health information, obtaining a thorough sexual health history is important. Reproduction and sexual issues are very personal, and sometimes they're really difficult to discuss. First, you need to gain the trust of your client, in addition to maintaining professional demeanor and sensitivity. Make sure you use gender-neutral terminology when inquiring about past partners. Usually, it's best to start with the least sensitive information and move on from there. This will allow you to gain your client's trust. One thing to take into account, particularly when questioning about any history of abuse, a wife won't admit to domestic violence in front of her partner. A teen probably won't necessarily admit to being sexually active in front of their parents. It's really important to find a safe environment to ask a patient about abuse if it is suspected. A more focused sexual history is asking about the 5 P's: partners, practices, protection, past history, and prevention. This was developed by the CDC. Partners, first off, you're going to ask the client whether they're currently sexually active. If not, ask whether they have been, and if so, when were they last sexually active. You're going to ask about the number of partners in total in the past 12 months, and whether they've had sex with just men, just women, or both. For practices, you're going to want to ask if the client engages in genital, anal, or oral sex, or a combination. Protection from sexually transmitted infections, what kind of protection or barrier methods are being used, and how often are they being used. For past history, you may want to ask if they have a past history of abuse, painful intercourse, or any other problems with the reproductive system. If they have a history of sexually transmitted infections, what kinds did they have? Were they treated? Were their partners treated? For prevention of pregnancy, are they trying to get pregnant? If not, what are they using to prevent pregnancy? Are they consistent with that method? And if not, what are their feelings on an unintentional pregnancy? So now we're going to discuss counseling for sexual problems and the PLICIT model. The PLICIT model was developed as a guideline for counseling sexual problems, and the first 3 steps are actually appropriate for nurses to be able to address sexual knowledge deficits. The last step, intensive therapy, is out of the scope of a registered nurse. So the first step is permission. This means that you communicate in an open, accepting attitude and allowing the client to be free to ask open-ended questions and express concerns and feelings and to engage in sexual behaviors with a consenting partner. For example, some women experience vaginal dryness after menopause. You may ask them, have they noticed this being an issue? The second step is limited information. Supplying limited information may include teaching about normal sexual functioning, expected changes in sexual functioning, medication side effects, and the medical surgical impacts on sexuality. The third step is specific suggestions. So you could make some specific suggestions for self-care as stuff with certain examples or things you've seen in your textbooks. For example, you may say to them that some women have found using an over-the-counter lubricant helpful if they are complaining of having vaginal dryness. So the fourth step, which is intensive therapy, if the previous suggestions do not help relieve a client's concern, you should refer them to someone with more specialized knowledge of sexual health, for example, referring them to their OBGYN. Common sexual health teaching topics. So you want to explore your client's knowledge base by asking open-ended questions such as, what questions do you have about sex? As part of your general discussion on sexuality and bodily function, you may want to discuss common myths and misconceptions about sex, such as not being able to get pregnant the first time you have sex, or not being able to get pregnant if you use a condom, or you'll always have symptoms if you get a sexually transmitted infection. Additionally, you may want to discuss basic perineal hygiene as well. With menstruation, you may want to discuss perineal hygiene during menstruation, as previously discussed. You also want to dispel any myths that the client may have such as you should not have intercourse during your period. You also want to discuss changing pads and tampons very frequently. Finally, you should also discuss comfort measures for mild cramping and other discomforts associated with menses, such as a heating pad, warm bath, or the use of NSAIDs. Premenstrual syndrome. Non-pharmacological treatments include getting adequate sleep, eating small, frequent meals, reducing sugar and caffeine, reducing alcohol and salt in the diet, taking vitamin and mineral supplements, and exercising. For perimenopause, you're going to counsel women to discuss the risks and benefits of hormone replacement therapy with their primary care provider. With preventing sexually transmitted infections, you're going to teach the clients the proper use of condoms and encourage them to discuss sexual feelings, activity, and safety with their partners. We're going to obviously dive into this much deeper in the next voiceover when we talk about sexually transmitted diseases. For contraception, clients who are heterosexual or bisexual, your sexual health teaching is also going to include methods for preventing unwanted pregnancies. So we're going to talk a little bit about contraception. I really want to stress that contraception is a lot more than just birth control. In addition to preventing pregnancy, depending on the method, it can also provide cycle control, treatment for painful menstruation or heavy periods. It also can be treatment for hot flashes in the perimenopausal woman. No contraceptive method is perfect, obviously. Each has its advantages and disadvantages, and some have complete contraindications. There are some methods that are more effective than others. In some cases, the effectiveness is influenced by user error. I know this looks like a long list of considerations, but honestly, it's really easy to get through once you're familiar with this list and the various contraceptive options available. The first consideration you want to make is safety. Obviously, that's the number one consideration. There are medical conditions that make some methods unsafe for certain women. For example, it would be unsafe for a woman who has a history of DVTs to take any method of contraception that has estrogen in it. Sexually transmitted infection protection, the only 100% method that's effective to prevent sexually transmitted infections is abstinence. When discussing contraception, patients really need to be aware of that. If they choose to be sexually active, the only methods that prevent sexually transmitted infections are the male and female condoms. Effectiveness is determined by how often the method prevents pregnancy. In a couple more slides, I have a chart that specifically reviews the effectiveness, so just stay tuned for that one. Again, abstinence is really the only 100% effective. Just to note, effectiveness drops significantly if the client doesn't understand the proper use of the method. Combining methods can also increase effectiveness. Acceptability. This is balancing effectiveness with what the couple is willing to use. For example, teens and young adults are generally reluctant to use IUDs because they don't want something inserted in their body. Convenience is another important factor. If a patient or couple feels like a method is difficult to use, too time-consuming, or too much bother, they are going to be less likely to use it consistently. For example, taking a pill every day at the same time may be difficult for some women to remember, and she may want to opt out for a long-acting method that she doesn't have to remember to take daily. Education needed. If a patient wasn't adequately educated on the proper use of a contraceptive method, they run the risk of unintended pregnancy. Natural family planning requires an extensive amount of training to be effective. Benefits. As I talked about earlier, some contraceptive methods offer other benefits in addition to strictly birth control. Some oral contraceptive pills have also the added side effects of improving acne, decreasing menstrual bleeding, or prolonged absence of menses. Some side effects on the flip side are some of the methods have undesirable side effects that women need to know about. So some methods, such as a spermicide, diaphragms, and condoms really need to be readily on hand to use just prior to intercourse. This can sometimes interrupt the mood, and some couples or individuals are not willing to incorporate this into their sexual activity. The availability. Is there a prescription required for the contraception? Can the method be purchased anonymously? These are really important factors. Think of the teen who's trying to hide their sexual activity from their parents. If they're not able to get it without a prescription, that means they have to go to a physician to get a prescription, whereas if it's something that's over the counter, they may be more likely to use it. Expense. Dependent on the method, will depend on the out-of-pocket cost. For example, IUDs can have a high upfront cost if they're not covered by insurance, But then the woman has, 3 to 10 years of coverage depending on the type of IUD. Oral contraceptive pills can be a monthly expense, whereas condoms can be a per use expense. Preference. This is ultimately one of the biggest driving forces in the decision on which method is chosen. Religious and personal beliefs. Some religions have a firm belief against the use of contraception and believe only in the use of natural family planning. This is actually true for Catholicism. Culture. Some cultures place high values on larger families. Others have restrictions during the time of the women's menses. This could influence women's desire to use a contraception that affects her menstrual bleeding. Some other considerations that they could include length of time between pregnancies, breastfeeding, and other factors. Another consideration is informed consent. For women choosing a surgical sterilization, hormone implant, and IUDs, an informed consent form is required. However, regardless of a method, all women should receive proper information about their chosen contraceptive option. Here's a list of non-hormonal contraception. For the most part, there are no contraindications to these methods unless you have an allergy to one of the ingredients. For example, if either partner has a latex allergy, latex condoms should not be used. Patients also would need to be cleared for surgery in order to have a sterilization procedure completed. Of those listed on the graph, the only method to prevent sexually transmitted infections are the male and female condoms, and they have to be used 100% of the time to prevent the spread of sexually transmitted infections. This is a list of the hormonal contraception methods. Hormonal contraception alters the normal hormone fluctuations of the menstrual cycle. The progesterone-only methods are the progesterone-only pills. So the Depo-Provera, the Mirena IUD, and the Nexplanon, the side effects of all of these are pretty similar: breakthrough bleeding and irregular menses. Many of these methods also leave the woman with no menses at all. The combined oral contraceptives, the patch, and the ring all have estrogen in them, and therefore they have a greater number of contraindications associated with them. Some of the contraindications include history of DVT, pulmonary embolism, or any other thromboembolic disorder, coronary artery disease, uncontrolled hypertension, smokers over the age of 35, active cancer, or a history of migraines. One of the most important teaching points that I want you to remember is ACHES, ACHES. It stands for abdominal pain, chest pain, headaches, eye problems, and severe leg pain. Basically, this is an acronym outlining the warning signs of oral contraceptive complications, the worst of which could be venous thromboembolism or stroke. Okay, so again, here's the ACHES acronym. This is really important to know these warning signs. Again, abdominal pain, chest pain, headaches, eye problems, any kind of visual disturbances really, or severe leg pain. So you want to educate your clients. Anybody that's taking any kind of contraceptives, if they have any of these symptoms, they need to contact their healthcare provider right away. So this is a chart that's just going to go through effectiveness from less effective to most effective. You should note that less effective methods are also the ones with the greater risk of user error.